I'm going to introduce myself. I'm David Ingis. I'm a clinical associate professor of medicine in the Department of Gastroenterology at the University of Pennsylvania. I practice mainly here at Radnor and at Penn Presbyterian Medical Center. And I've been in practice prior to coming to Penn for 34 years and then 2 additional years here at University of Pennsylvania. So we've done probably 30,000 colonoscopies over that time. We do about 1,000 a year. So it is a large percentage, and it's a very important test. We're going to be talking today about colon cancer screening. This is colon cancer month, the month of March, and it's very important. And today, on the Today Show, there was a live videotaping of a colonoscopy, so you all can look in on that, probably get it on the computer, probably on MSNBC, you probably be able to pick it up. Colorectal cancer is the 3rd leading cause of cancer death in women, the 2nd leading cause of cancer death in men, and causes 10% of all cancer deaths in this country. This is a schematic of the colon. It is 5 feet long, which means our colonoscope, when we put it in, is also 5 feet long. When we do a colonoscopy, and we'll talk about this in more specifics, we're going to be looking for little growths called polyps. They look like berries on a vine, or strawberries, or mushrooms, probably the best description of them. And they have the potential to turn into cancer. And that's why we do a lot of the procedures that we do, and we'll talk about that. The statistics from several years back, approximately 48 to 50,000 deaths per year from colon cancer, the same number as die from auto accidents. So it's obviously a very big total, very important disease. And the importance of this talk is that this cancer is preventable, it's curable, and we know that screening will reduce the incidence of mortality. So if you're not being screened, you need to be. Now, colon cancer can occur in many different ways. It can be sporadic in that there's nobody in the family who's had it before. There is an inherited increase in colon cancer. And the way cancers start, and the theory behind colonoscopy, is that first you get a polyp, which is a certain kind of polyp called an adenoma. This adenoma is an abnormal growth, but not yet a cancer. Over a 10-year period, some of these polyps will turn into cancers. Only 1 out of 20 will turn into cancer. However, when we look at the polyp, we can't tell, the polyp doesn't tell us that it's going to turn into cancer or not, so we remove all the polyps. And therefore, that sequence can't occur. The polyps are distributed everywhere in the colon. They're on the left side and the right side. In the old days, when we used to do a sigmoidoscopy first, we would only see the left side. We wouldn't have any idea what was going on here. And then if we followed that up with a barium X-ray, we could see both sides. But it's been learned that barium X-rays miss about 20% of the polyps in cancers. So it was an imperfect test, but it was the best that we had. And that's what we had when I was in medical school. So we all learned how to do rigid sigmoidoscopies, which meant putting a rigid pipe up the colon, only up to this distance. And that was usually quite painful. It wasn't done with anesthesia, and it was usually very uncomfortable for the patients. So it was not a great test, but it was the only thing available. Now, polyps are these growths. They can be of 2 kinds. Sessile means that they're flat, and an example of that would be something like this. I don't know how well you can see that. And the other kind is called pedunculated, which means it's on a stalk, like a mushroom. And the cancerous part, or the part that can turn into a cancer, is on the top. Hyperplastic makes up 1/3 of polyps. Hyperplastic polyps are inflammatory. They carry no cancer potential at all. So if you're going to have a polyp, that's the one to have. And when we send out our letters after the test is done, we tell the patients which ones they have. If you have an adenoma, you need to have surveillance exams in the future, and we'll talk about that. If you have a hyperplastic polyp, it's the same as having nothing, and you're good for 10 years. And that is the recommendation. Everybody should get it every 10 years. The incidence of polyps at age 50, about 25% of people have them. When you get to 70, about half the people, the patients, will have a polyp. So when we go in, we'll find 1 out of 4 patients will have a polyp, and 1 out of 20 of those polyps will turn into cancer if left in there. There was a study group done several years back called the National Polyp Study, and this is where we got the numbers that it takes 10 years for polyps to develop. And they studied 1,400 patients after removal of polyps, and they noticed there was an 88 to 90% decrease in cancer. They also noticed that Afro-Americans had a greater number of polyps and cancers than Caucasians, and that it begins earlier in Afro-Americans, so that the American College of Gastroenterology, which is one of our 3 major gastrointestinal organizations, recommends colonoscopy starting at age 45. Not all the insurance companies, however, agree with that, but they all, by state law, both here and in New Jersey, have to pay for a colonoscopy at age 50. And we fought hard to get that passed in New Jersey when I was there. Both us and the American Cancer Society were very successful in making that state law. Now, certain patients are at increased risk for getting polyps and further cancer. If you've had a colonoscopy and you've had a polyp before, then, or a cancer, you are at increased risk of doing it again. Your colon has shown that it will make cancers or polyps. Therefore, if you've had a polyp, we recommend, if you have 1 polyp, that you should have a colonoscopy in 5 years. Now, that used to be, when I first started, it was 1 year. Then it went to 3 years. Now it's 5 years. Because they feel, the feeling from the National Cancer Polyp Study is that you can go that long once the colon has been cleared. If you have inflammatory bowel disease, ulcerative colitis, or Crohn's disease, both inflammatory diseases of the colon, you have an increased incidence of getting colon cancer and need to be screened starting at after 8 years of having the disease. And we usually screen those patients once a year. When they do get cancers, the cancers often are more aggressive, spread faster. So we want to pick them up at an early stage, if at all possible. Also, if you have first-degree relatives, parents, brothers or sisters who have had colon cancer or colon polyps, you are at increased risk, should have a colonoscopy every 5 years. That is the recommendation currently of the Endoscopy Society and the 2 gastroenterology associations. Somebody mentioned that they were getting it every 3 years. That's a little aggressive, but it certainly wouldn't hurt if you want to do that. But the recommendation is every 5 years. If you do have 1 colon cancer, it does mean that you can get a second one. I have a very young patient who at age 21 had a colon cancer. Very unusual to have colon cancer at age 21. About 12 years later, he came to see me for something unrelated to his first colon cancer, and I had not seen him at that time. I said, well, you know, you need another colonoscopy. Well, we went in and colonoscoped him, and sure enough, he had a second cancer. He was now 34. We took that cancer out, and he is a survivor. He has subsequently gotten married, has 2 kids. Luckily for me, he's a banker, and I get good mortgages. But seriously, you know, had he not gotten that second colonoscopy, it would have been too late. And he should have been doing it every 5 years. Usually, if you have a colon cancer, we recommend 1 year later, then 3 years, and then every 5 years, assuming that the first 2 exams are normal. And that way we can prevent that second primary. You also are at increased risk if you have multiple polyps at the time of the first colonoscopy. So if you have 2 or more polyps, actually 3 or more polyps, then we recommend, instead of waiting 5 years, to do it in 3 years. And if you have a flat polyp where we're not sure that we got the whole polyp out, or that we're a little upset about that it's not yet a cancer, but it's a little bit more aggressive than the usual kind of polyp, the polyp's called villus, then we may recommend that you come back in 6 months or 1 year for that second colonoscopy, just to be 100% certain that we've removed the polyp and that it's not going to regrow in the same spot. Okay. This just summarizes what I just said about the increased risk once you have a colon cancer. And if you have the multiple polyps, or if they're what we call villus. Villus is a certain kind of polyp. When you have an adenoma, if their growth is in a certain pattern, it's called a villus adenoma, and that has a higher cancer potential than what's called a tubular adenoma. You don't need to know those specifics, other than if you hear that word, you know that that's something you have to do. Inflammatory bowel disease, if anybody here has it, the risk increases with the amount of colon that's involved. So if you have ulcerative colitis and it's only up to here, what we call proctitis, starting here, going up to here, no cancer risk. If it goes up to here, there's an increased cancer risk, and as you move along, the cancer risk increases. Once you have total colon disease, then you have to be screened after 8 to 10 years. And we look for early changes, not necessarily cancer, but something called dysplasia, which means that the lining is starting to turn into a cancer. And at that point, we remove the colon to prevent that from happening. But that usually doesn't happen until more than 10 years, maybe even. And as the patient gets older, the risk increases. So if you have the disease for 20 years, you have more of a risk, and then 30 years, more of a risk. So at some point, if dysplasia occurs, you're going to have that colon out to prevent colon cancer. Family history, 10% of our patients have relatives with colon cancer or colon polyps, and that represents 25% of all the cases of cancer that we see. We're very concerned, particularly if there is a family history of polyps or cancer before the age of 60. If you have relatives with an early age of onset of the polyp or cancer, that increases by, you can see, 6% the relatives, the chance of the relatives getting another cancer. So if the earlier your relative has cancer, the more serious you should take this, and you should be screened. If you have a relative who has cancer at 40, you should be screened at 30, 10 years before. There is a condition called hereditary nonpolyposis colon cancer syndrome that causes about 3% of all colon rectal cancers. And what happens there is that patients have relatives with different cancers any of those that are listed, but colon cancer is in 3 generations. So a grandfather, an uncle, and a son, and then that really increases the incidence, and those people need to be screened every year. And we're looking for, in particular, for people who have colon cancers at younger ages. So you get it at age 30 and 40, those are the patients we start looking for that. And there are genetic testing that can be done to determine whether you're in that group and therefore whether you need to have more frequent colonoscopies. There's another condition called familial adenomatous polyposis, which is a genetic disease, occurs in about 1% of our colon cancer patients. And these people have millions of polyps. It looks like a carpet of polyps throughout their colon. And from age 17 on, they're at high risk of getting colon cancer, and they have to have their colons resected early. When I was in the Air Force, I was in the Air Force in practice for 2 years. One of my patients on her way out said, "Oh, by the way, my mother has all these polyps in her colon." Well, it turns out she not only had familial polyposis, but she herself had a colon cancer. And 20 years later, the surgeon who I worked with in the service, who went into practice in Pennsylvania, sent me the daughter of that patient, and she also had the condition. So we saw 3 generations. It's not so uncommon. We do genetic studies here at the University of Pennsylvania on this group of patients. There are other conditions that are not that important for you to know. Gardner syndrome is similar to familial polyposis. The patients have different kinds of tumors in addition. Cowden syndrome has polyps, and I had a young man who had a colon cancer there, and his wife got so angry that he had that condition and maybe gave it to their kids that she divorced him. Radiation therapy for prostate cancer, which we see a lot of, does increase your incidence for colon cancer, and so is something that needs to be checked. In 2008, a task force from the United States task force went over all the screening tests for colon cancer, and this will answer some of the questions that you've asked before. And the whole point was that our goal should be prevention of colon cancer, not finding the colon cancer after it occurs. And so that our tests should be looked at in that line. If the test can prevent us from developing colon cancer, it's preferable than having a test which shows us that the colon cancer is there, although that's better than nothing. So the first test were the fecal occult blood testing, and those were done every year. And if positive, then a patient would be referred for a colonoscopy. There's a large false positive and false negative on those fecal occult blood tests. I had a relative who had a negative fecal occult blood test, and 4 months later was found to have a colon cancer, which was eventually fatal. So you can't count on that as the end test. Double contrast barium enemas were the test that we used to use. Double contrast means that you put the barium in and then you put air in on top of it. Very uncomfortable when the air goes in, and it doesn't show everything. There's a large miss rate, so it's really not done very much anymore. About the only time we do it is if we do a colonoscopy, and I had one today where I got down to here, but I couldn't see the last segment, and I didn't want to take a chance that in that last segment there was something. So that patient will get a barium enema because it was the only other thing to do. And we worked on this gentleman for over an hour, but we just couldn't get down to the last segment. We call our colonoscopies, to differentiate it from the CAT scan colonoscopies that I'll talk about in a second, optical colonoscopies. We're looking with our eyes at the colon. CT colonoscopy is also known as virtual colonoscopy. You've heard about that. Our president just had a virtual colonoscopy at age 47 and immediately received a letter from the president of the American College of Gastroenterology saying he had had the wrong test and he shouldn't have been having that test. He should have had an optical colonoscopy so that if he had something, it could have been removed at the same time. Stool DNA testing is something that is coming. It is not yet on the horizon, but we may be able to pick up early cancers by doing DNA studies on the stool. The fecal occult blood testing, there was a big study in 1993, and it showed that it did reduce mortality by 33%. And the sensitivity of one test was 30%, and if you increase it to 3 tests, which of those of you who have had it, that's what you do, you test 3 consecutive stools, then you get an 80 to 90% sensitivity, which means it picks up that there's something wrong. Then when we go in and look, we only find cancer about 4% of the time. So other things bleed other than cancer. It can even be a nosebleed, anything from the top, esophagus, ulcer in the stomach, small intestine. All those things will give you blood that can show up on an occult blood test. So it's not 100%. The Hemoccult Sensa, S-E-N-S-A, is a better test than Hemoccult 2, but I've yet to see it used anywhere. We're still doing Hemoccult 2s when we do them. We do rectal exams when we see our patients, but a single rectal exam, positive or negative, is not an adequate test for colon cancer screening. So if you go to your OBGYN doctor and they do a rectal as part of their pelvic and they tell you the stool is negative, that's not good enough. You still need to have further testing. As I mentioned, 3 stools, 2 samples on each card, 3 cards. And if the stool is positive, you have to have a colonoscopy. You can't just ignore it and say, well, let's do 2 out of 3. I've had patients do that. Well, let's do it again. Well, then that second time it's negative. Well, then what do we do then? We do it a 3rd time. You don't do that. You go on and you get the colonoscopy and you find out what's going on. There are fecal immunochemical tests that will be coming out on the stool, not yet available in this country. They're going to be more expensive. Everything we do is more expensive, unfortunately. And it has an increased sensitivity for picking up cancers, but it's not very good for picking up the polyps, which are the precursors. You have to bring a whole stool in an ice pack. You can imagine how much fun that's going to be. But it's done every 5 years, and it has a reasonable sensitivity, which means it picks up an abnormality, and it has a high specificity, which means that if it picks up an abnormality, the abnormality is real, that there is a cancer. So that test is on the horizon. It is not yet here. Barium enemas, an old test that we're not doing anymore. 50% of all polyps are seen if they're greater than a centimeter. You then need a follow-up colonoscopy. There's lots of false positives. A piece of stool standing in one spot looks like a polyp. It's more sensitive than the occult blood testing. But like I said, its use is markedly decreasing. And as its use decreases, the radiologists who do these barium enemas will be less skilled in reading them. So the test will be even less effective than it has been in the past. Sigmoidoscopy goes up to 60 centimeters. We now have a flexible sigmoidoscope. in this, so it's like a small colonoscope. And it can be positive. It can reduce colorectal cancer mortality, but it's not as good as a full colonoscopy. And if you get a positive test, then you still need a full colonoscopy, so you might as well just do it. The only time I do a flexible sigmoidoscopy now is when I have a patient who I've done a colonoscopy on and found something or not found anything, and then they come in again with bright red rectal bleeding, which probably is from hemorrhoids. We've already cleared the whole colon, so I'll go up and just be sure that we haven't missed anything in the lowest section and do a sigmoidoscopy. Or if somebody's 20 years old, you know, where the risk, forgetting my banker friend, that's very unusual. He's the second youngest patient I ever saw with a colon cancer. I did see somebody age 18 when I was in the service with an obstructing colon cancer, but that's very unusual. It usually starts at age 50 or 45 in Afro-Americans. Test has, this is not usually done, but if you did both fecal occult blood and a sigmoidoscopy, in one study it showed that it was 75% sensitive, but nobody really does that. What we push, and what I think is the test, and the test I've had on myself twice, is a colonoscopy. The colonoscopy not only detects the polyp, but it takes it out at the same time. We remove the polyps, we lasso them, and we remove them. We send them for analysis. It detects most cancers, but it's not 100% effective. We tell our patients that there are misses, that it's about 90% effective. There was a recent study that actually showed, and it's a very controversial study, and I'm not sure what to make of it yet, that we decreased the incidence of colon cancers on the left side of the colon, this side, but not on the right side with colonoscopy. Now there could be some reasons for that. Sometimes the polyps are very flat and they're hard to see, and they can develop into cancers. And so the theory is that perhaps we're missing some of those, and as the techniques get better, we'll be picking up more and more of those. But that's the first paper like that. And you know, I don't really know if that's going to turn out to be accurate. Well, the study, what they did was they did a national polyp study. And they found that there were very few cancers, not none, but very few that developed in that 5-year period. So that the feeling was that not many were being missed, and if they were being missed, they were very small and weren't growing into cancer. So they had to choose some interval, and they chose 5. People argue with that. You know, nothing, you know, next year it may be 3. Or if, you know, healthcare plans and we can't afford it, it'll be 10. I mean, you know, one doesn't know. But right now, the guidelines from the gastroenterology associations are 5 years if you've had one polyp. What's that? If you have more than one, if you have 1 or 2, 5 years. 3 or more, 3 years. Well, the two most common causes of, the two most common symptoms of colon cancer are bleeding and pain. And what? And pain. We also look for change in bowel habits. Somebody develops diarrhea when they were constipated, or the reverse, constipated when they used to have normal bowel movements. I personally have not found that a very useful predictor of what a patient was going to have, but the insurance companies do approve that as a reason to have a colonoscopy. So, you know, it's felt by some that this is a reason to do it, and therefore when the patients have this change, we do it. But in my own experience, I haven't really seen too many patients who come in and say that, you know, they've got a flat stool, you know, it's flat on one end, that kind of thing. That usually turns out to be spastic colon, more than cancer. But if they're having abdominal pain and bleeding, that's a different story. Bleeding in particular is worrisome. I mean, that's what we're looking for with the stool tests. When the patient comes in and they tell me they've had blood, they get a colonoscopy. So it's not 100%. And it's not a good test for polyps because polyps usually don't bleed. It's a better test for cancer, but we want the test for polyps. And the test for polyps is the colonoscopy. And if you think about it, if you're doing a colonoscopy you do your colonoscopy and you have nothing, and then you do it again in 10 years and you have nothing, you don't need to do the stool for occult bloods every year. If you want to, fine. And then if it shows something, you can have another colonoscopy. But I don't think it's necessary. And certainly if you have a polyp, then you're going to be surveyed more closely, and you don't need to do the screening either. There are a lot of small sessile polyps. The big sessile polyps are the ones we worry about because they're the ones that turn into cancer faster. If there's a question, we can mix methylene blue with saline and shoot that in to see, but that's just starting. And there's a whole series of so-called colonoscopies with solutions that will be done in the future. But right now it's not standard of care, so we're really not doing it on a regular basis. And that's done more for the inflammatory bowel patients than for the regular patients. And there was a question earlier about the difference between Radnor and Penn Presbyterian or HUP. We all use the same scopes. We all use high definition scopes. Here at Radnor, we have anesthesia available so that every patient is asleep with a general anesthesia. We like to joke that it's the same medicine that Michael Jackson took, but the doctor doesn't leave the room. But at Penn Presby, we will have that availability in July. Right now, we're doing about 2/3 of the patients with that kind of anesthesia. But the other kind of anesthesia is called conscious sedation, and it's equally effective. It just takes longer for the patient to wake up when the procedure is over, and that's a gradual injection of medicines called fentanyl and Versed. And the Versed has the ability to make you not remember that you had the test. So people wake up in the recovery room, and I've had patients who have refused to believe that they had the colonoscopy until we showed them the pictures of the end of their colon. So it's a phenomenal medication, and works. It's just slower than the propofol that the anesthesiologists use. But the patients have very successful. My colonoscopies were done with conscious sedation, and I don't remember them. I know the first one I was trying to direct the doctor who was doing it, and he gave me a little extra dose to put me to sleep so I would shut up. As I said before, in the National Polyp Study, when they cleared the patients from polyps, there was a large reduction in advanced lesions. But there's not been a comparative study done where you took people at age 50, gave half of them colonoscopy, half of them no colonoscopy, and followed them for 30 years to see what happens. That study will never be done. Sort of like the Framingham study but in Framingham they studied all kinds of parameters over a long period of time. But you can't put people through a study like that when you have quite a good idea that colonoscopy is going to make a big difference. I mean, would you want to be in the non-screen group? Risks of colonoscopy, this came up. Perforation occurs 1 in 1,000. If it occurs, you usually discover it right away. And emergency surgery can be done, and it can be done with a laparoscope. So recovery time out of hospital in 5 days and back to normal. Bleeding occurs also in about 1 in 1,000 cases. Bleeding occurs when you take a polyp out. If you don't cauterize it properly, or if there's a large blood vessel under it, it can occur as much as 4 weeks later. If it occurs, we usually can either go back, it'll either stop on its own, although it's scary and sometimes the patients are put in the hospital and watched, or you can go back with the scope and coagulate the area where the polyp was and stop the bleeding that way. Very unusual to have surgery for bleeding. So surgery for perforation, recoagulation for bleeding. Missed lesions happen. It's hard to determine why that happens. There have been studies that show that we should be removing the scope over a 7-minute period. And the 7 minutes means that you're slowly removing the scope. And then there was another study that showed that perhaps the most important thing was the colonoscopist, not how fast he took the scope out, but how careful he was and how good an eye he had in removing and seeing the polyps. And it's a funny thing because as you remove the scope, sometimes you don't even see it. You just get a feeling that something abnormal was there, and you go back and there's a polyp. It's like a subliminal sensation that you've seen it but didn't recognize it at first. And I guess that happens after you've done a lot of cases. Colonoscopy is expensive. The worst part is the bowel prep. I've had 3 colonoscopies. I've had 3 different bowel preps, and I'm looking for the 4th prep for my next one. Actually, we now have a new prep, which is actually palatable, unlike the others that tasted a lot like seawater from the ocean. We actually take Miralax, which is an over-the-counter preparation short for miracle laxative, and we put it in Gatorade. And there's a mix that we use, and the Gatorade masks the taste. And the patients have enjoyed that considerably compared to the previous prep. The prep is probably the hardest part because there's a lot to drink. And you have to be on clear liquids the entire day before so that when we look inside, we don't see any stool. Because if there's stool in there, that can mask polyps. Things can hide under a clump of stool and we won't see them. So prep is very important. And the bowel prep is done for both virtual colonoscopy and regular colonoscopy. So there's no preference between the 2 studies as far as the prep. You have to have the same prep. The nice thing about our optical colonoscopies is that if we see something, we can remove it. If you have a virtual colonoscopy and you're one of the 5 with a polyp, guess what? You now have to have a regular colonoscopy. So you have 2 tests instead of 1. And you'll find that your insurance, at this point in time, will not pay for it. Medicare, for example, will not pay for virtual colonoscopy, only if you're president of the United States. And now I talked about the different kinds of sedation, either conscious sedation or anesthesia. Yes, sir?
The reason for the sedation or anesthesia is what? Pain when you do it? Or?
Yes. Yeah, we go around corners. If you look at the colon here, and this is a very schematic colon, it's not even this easy a turn. Sometimes the colon goes like this, and then down, and then up again, and over here it tips all the way down and up again. So when we go up and down these curves, we pull on the mesentery, which is the lining that holds the bowel to the belly, and that can be uncomfortable. Usually the patients, even if they groan or make some noise that it's hurting, they don't remember it when it's over. But it's a sign to us that we should pull back, ease up, and then advance again. The whole test usually takes about 20 minutes, and when it's done, we can go at the patient. The patient will be awake at the end of that time. And when I come out, for the most part, I can tell the patient, and we show them the pictures that we took, and they get a report. And so everything is explained to them, except that if we took a polyp out, we have to send it for analysis, so we can't tell them that, but we do send them a letter that tells them what, and we also encourage the patients to call because you want to make sure that you find out what your polyp was. So we like the patients to call as well as us sending a letter. That way nothing gets missed.
When will you use merely sedation as opposed to anesthesia?
If anesthesia is available, we tend to use it, only because it's faster. It's faster in that the patient goes to sleep faster and they wake up faster. But if we give conscious sedation, then we give it gradually, because everybody's different. So we have to give a shot, wait a few minutes, give a shot, wait a few minutes. So there's 10 or 15 minutes before we actually start the procedure. Whereas with anesthesia, they press a button, in goes the medicine, the patient's out completely, and we start. So we gain time, and if you add that up over a whole, a 15, let's say a session where 15 patients are being done, not necessarily by the same person, but that's a lot of time saved or lost. But in terms of the individual patient, it probably doesn't matter. Well, the 7 minutes is because we all tend to, at least most of us tended to withdraw a little faster than that if we didn't see anything. But there was another study that was done at Harvard and recently published, and what it showed was the time was not important. It was the skill of the colonoscopist. So the time may not be important, but we're all slowing down and doing it, 7 minutes, 8 minutes. As one of our colonoscopists said at a recent course, you can get to the bottom here, look around here for 5 minutes doing nothing, and then take the scope out at 2 minutes. Is that 7 minutes? So we slowly come back, and what I've done now is I only come back 10 centimeters at a time and look at the whole 10 centimeters and then come back another 10 centimeters. That slows me down instead of just slowly pulling it out. But usually you see things, like I said, subliminally, or, you see it right away, or we've got 6 eyes looking at the scope. So we think we see most of it. However, there have been studies where somebody has a colonoscopy, and then immediately thereafter another colonoscopist does the study, and they find up to 20% of polyps that weren't found in the first study. But it's still the best test there is, but it's not 100%. The newer scopes, what's called the 180 series, have a hose that's attached that we can spray water in the whole time. So we try to wash off as much stool as possible, but sometimes you just can't. And I had such a case today where there was just so much material in there that I told the patient that, we didn't see anything, but you're not going to wait 10 years. You're going to do it in 3 years. And, that was a number that seemed reasonable. I might have missed a little polyp under some of the stool, but nothing big. And so that would be, enough time so that it would still not have grown into something if I did miss a little polyp. We had the ability to videotape when it first came out, but we soon realized that nobody had the time or the inclination to look at the videotapes. So we take pictures. We take pictures of everything abnormal. Videotapes are made for teaching purposes, but not, no one's going to sit and watch a 20-minute videotape. Let's say you did 15 patients. You're going to watch a videotape. I mean, who's going to watch it? The patient? I don't think, nobody does that. Right now, our scopes are what we call 19 French, which is about 6 to 7 centimeters. I mean, there's They're small.
Millimeter or centimeter?
Centimeter.
Millimeter?
It's like the size of my thumb, my finger. I don't know how big that is.
So how can you bend for a sharp angle to do that?
It's amazing how flexible these scopes are. They really are.
You pushing, they bend by itself.
No, we have 4 guides. We can turn it up and down, left and right. We can also torque it. So we can turn it around. If I have a polyp on the top of the bowel, let's say it's up here, and I want to bring it down here because it's easier to remove down here, I can turn the scope around by twisting. And the polyp will come down here, and then I can take it off. So it's much, believe me, I used the original scopes, and they weren't like that. The first scopes we had were 2-way deflecting. And if you got to the end, to the cecum, you were considered Houdini. I mean, because it was very unusual to do that. And I remember one of my friends went into practice, and he had, as his senior partner, someone who could get in there all the time. And he was very frustrated because he could only get to the to the transverse colon. And he said, they expect me to get here every time, and I can only get here. Well, now we expect to get there every time. And if we don't, then we get an X-ray or we get a virtual colonoscopy to make sure that we haven't missed anything. We can't stop and say, well, we only saw 2/3 of your colon, come back next year. You know, we don't want to do that. Because if there is something there, we want to take care of it this year. So those are the experience of the colonoscopist. The most important thing, we talked about the 6-minute withdrawal. We talked about the tandem colonoscopies, which was one colonoscopist followed by another. And even large polyps were missed by the first colonoscopist. It's a little scary, but it is still the preferred test for screening for colon disease. The virtual colonoscopy, same bowel prep, no sedation. There is abdominal cramping, therefore, because they have to put in a lot of air. There is some, in the future, we will be tagging the stool contents with radioactive or some kind of material so you won't have to do the prep. And the contrast will be able to differentiate stool from polyp. However, that's not yet available. And the real problem is that you need readers who really know how to read these kinds of studies, so that the difference between virtual colonoscopies done at a university center and done at a virtual colonoscopy unit out in southern New Jersey, let's say, is going to be totally different. And so, you know, if you're going to get one, you want to get one where they do a lot of them, and the radiologist has special training in virtual colonoscopy, and that's new. It's a whole new field. Now, 10 years down the road, that may all change. But right now, it's not the case. Right now, the test to get is a colonoscopy, and when I'm due for my next one, it will be an optical colonoscopy again. And if we find something, one second, if we find something, then you have to have your colonoscopy. So the only, you know, but if you look at it, the entire colon is seen. There's very little risk of perforation, almost zero. So those are the preferences. We don't know about cost effectiveness studies. It is much more expensive than a regular colonoscopy at the present time because of the machines that they use. And there was one study on high-risk patients, and they seem to prefer the optical one. So the joint guidelines for the American Cancer Society, the multiple task force that I mentioned, and the American Society of Radiology recommended trying to do prevention rather than early detection of cancer. Screen at age 50. it's now recommended to stop screening if your estimated lifespan is less than 10 years. Hard to tell when that is. It's getting younger every day. But certainly you should decide with your doctor. When my father hit 90, we decided colonoscopy was not necessary anymore. It should be every 10 years. The virtual colonoscopies are recommended every 5 years. And if the polyp seen is greater than 6 millimeters, then the patient should be referred for a colonoscopy. And that's very controversial because I have seen cancers under 6 millimeters. So that not often, and you don't think it's going to be, and then you're shocked when it happens. Flexible sigmoidoscopy is recommended every 5 years if you're going to use that. And if you're going to use the double contrast barium enema, the recommendation for that one is also 5 years. Screening for early cancers, these are the things that are coming down the road. The DNA testing and the immunochemical testing. I mentioned all of this before. This is the recommendations. You can read through them. 1 to 3 polyps. If you have a large polyp, which I didn't mention, if you have a polyp that's more than 2 centimeters, then that should be checked every 3 years. And if you're, as the colonoscopist, if you're not 100% certain that you've gotten it all out, then you want to go back even 3 or 4 months later, or depending on what your thoughts are, sometimes a year. I had one today where I was quite sure I got it all out, but I wanted her back in a year just to be sure.